Okay, welcome everyone to Studio Q and QLI's webinar series. My name is Steve Kershke. I have Dr. Jeff Snell in studio. We have Don Terry joining us remotely. Don, thanks for joining. And the topic today is the role of cognitive behavioral therapy in brain injury rehab. Dr. Jeff Snell is a regular presenter here. So Jeff, thanks for joining us again.
Yeah, glad to.
And before we jump in, just quick intro. Those of you who are regulars on our webinar series, welcome back. We really appreciate you joining us and tuning in. Those of you who are new to QLI is based in Omaha, Nebraska. We are a post-acute brain injury, spinal cord injury rehabilitation provider. We serve individuals from all over the country who come to QLI on our campus and then eventually transition back into the real world. We also have a community-based continuum where we provide tele-rehab services to some of those same individuals, as well as individuals who don't make it to QLI. So a little bit about us. We really appreciate you joining as well. One piece of housekeeping, just as a reminder, CEUs. We do provide CEUs. These are CCMC CEUs only. We don't offer them for adjusters or any other certifications. But in order to get your CEU, you have to answer the CEU poll question, which will be presented at the end. And then following the presentation today, typically within just a couple hours, it will not be immediate. You will get an email that has a webinar evaluation, which will then trigger the sending of your CEUs and the slides. So we'll do another quick reminder of that at the very end, but hopefully we can avoid any confusion on that. But with that, Jeff, we're talking about CBT today, and I love the fact that you have some relevant content to talk about. Jeff's going to be moving here shortly, and it sounds like you're doing some personal treatment on yourself, or what?
Oh, no, actually, I'm taking a couple of vehicles and a bunch of fragile stuff down to the new place, and it's only about an 18-hour drive. So, yeah, I'm going to start that process today. So.
Yeah. Well, and then some of the concepts we're talking about today might be helpful along the way.
All the potential catastrophizing and yeah, exactly. So I have to remind myself as well to use some of these strategies to kind of back that down a little bit and challenge those belief systems so that I don't needlessly worry and make myself overly anxious.
Yeah, isn't it interesting, even as I would consider you an expert, maybe you're too humble to say so, but as an expert who knows a lot about this topic, the difference between knowing and actually executing, it's a big difference, don't you think?
Well, I mean, it's, as we'll talk about, it's such an automatic process for all of us that regardless of how much you know about it, you still fall into the same pitfalls, the same traps, because that's just the way our brains work.
Mm-hmm.
There's a lot of stuff that operates at a very automatic level within our brains, and evolutionarily that's beneficial to us. It allows us to use former knowledge and experience and predictions in a way that is meaningful and purposeful and actually makes things work more efficiently.
Mm-hmm.
At the same time, there are some negative side effects of that, as with anything.
Yeah. Well, I know we're talking about brain injury rehab today, but what I love about hearing you speak is many of the concepts, even as we've alluded to right now, can be applied into our own lives. If you're an individual who works with maybe a different population of individuals, be it spinal cord injury, limb loss on the more catastrophic side, I think these definitely apply. Individuals who work with maybe more run-of-the-mill types of injuries, low back pain, that sort of thing. I use this with my kids, so I always look forward to hearing this topic. And so with that, I'll turn it over to you, and hopefully we can have a little bit more dialogue along the way.
Great. I appreciate that. And Don and Steve will both be monitoring the chat during this presentation as well. So as questions come up, please feel free to go ahead and pitch those out. If I can, I'll address them in a moment. Otherwise, we'll have a little bit of time at the end for questions as well.
Yeah, just to clarify, use the Q&A, not the chat, for that if you have questions.
Well, I just gave you the first wrong instruction of the day. So, one for one. So what we're going to be talking about today is the role of cognitive behavioral therapy, particularly in brain injury rehabilitation. And as Steve alluded to, this is something, all the tenets, all the principles that we're going to be talking about are things that apply to everyone, basically how the human mind works. But there are some particular adaptations and things to be aware of in working with a population of individuals that may have emotional behavioral dysregulation following brain injury and the neurological issues behind that. So we're going to talk about the what, why, and who when it comes to the use of CBT in brain injury rehabilitation. What really being the process of what CBT is, why as to how it is helpful with this population, and the who as well, going along with who can best benefit from it, or who are individuals that there may be some substantial adaptations needed. So let's start with the what CBT is. Cognitive behavioral therapy is a process of addressing and treating emotional disturbances. Also, you could lump behavioral disruptions in there as well, that really developed in the mid 20th century. Aaron Beck, Albert Ellis, David Clark, David Barlow, those are some of the names that are predominantly associated with it. Aaron Beck developed a lot of the theory associated with it. Albert Ellis is somewhat famous for his means of executing this with individuals. And if you do a YouTube search for Albert Ellis and his therapy process, you'll see a very abrasive old man who really just didn't have time to deal with all the fineries. And
Man, Albert Ellis is great.
well, I think that's, a lot of people, that's their first exposure in therapeutic approaches, because, CBT has been around a long time. And there is some danger, certainly, of attempting to emulate his style without having his knowledge and experience behind it. But it can be amusing at times, and we'll talk a little bit about that as we go. The process really is looking at the relationship between our internal belief system. You could think of this almost as biases, things of which we are not typically consciously aware, but from an evolutionary perspective, allow our brains to automatically make decisions, make predictions, and act on those. Those internal belief systems result in our actions and our behaviors. They also result in our emotional state when it comes to our own self-evaluation and how we fit into the world. The process of CBT really is looking at how can we address the role of those automatic beliefs, what were called core beliefs, in our internal thoughts and in our subconscious reactions. I'm going to be talking about CBT from the standpoint of bringing in cognition, but really it is what would be considered a second wave of psychological therapeutic interventions. First being behavioral therapy, second being cognitive behavioral therapy. That's considered second wave, which has now led to the evolution into third wave approaches. And those are things like acceptance and commitment therapy, dialectic behavioral therapy, mindfulness-based cognitive therapy. These are all considered third wave approaches, but all of them utilize principles and theory that are based upon this notion of our internal belief system, and changing that through experiences to some degree, emulating what we see in others, and gaining knowledge. As human beings, Steve, we are basically very hard-headed, and we don't learn well just by being told something. We actually have to experience it to incorporate that within our belief system. And so that process of being able to challenge, think of it as a scientist challenging a theory, challenging some of those beliefs by experience, and through that experience, altering those biases and altering those internal thought processes. That is really what the goal is when it comes to CBT. So again, addressing these, what you would consider maladaptive or problematic behaviors, emotions, and thoughts by systematically challenging these. And again, a very goal-oriented process. Systematic and goal-oriented really can't be overemphasized when it comes to CBT. CBT is best utilized with an identified target goal, with an issue or target behavior. It's also important to note that CBT is considered to be a time-limited therapy process. In other words, it's not an endless lifetime of therapy for a given. So identifying a specific goal that you want to work toward when it comes to your own emotional health or behavioral issues as well, it applies equally. and then specifically addressing that systematically, typically over an 8 to 12 week program, with the expectation that because you are altering your own internal dialogue, you will carry that with you moving forward. And so you basically kind of build on that.
Yeah, you answered where I was going to go. It's a finite amount of time,
Yes.
right? Because there's a problem, or you've identified a certain issue, and you're going to have a methodical approach to that. It's not something that's considered maintenance based per se.
Yep. And probably even more the case when you're talking about working with individuals, as we do at QLI, for those who have had, severe traumatic brain injuries or anoxic brain, basically severe acquired brain injury. That process of recovery also changes that target as you move forward. And so that can be addressed in many different ways during different stages in recovery. And that's something we'll talk about as we get toward the end here. So basically, the process of CBT is attempting to address these internal belief systems and change them through our experiences. We want to align our internal belief system with that is most realistic when it comes to our actual world that we live in. When our expectations are dramatically different than the reality of the world, we tend to be upset. We tend to be irritated, agitated, frustrated, angry, depressed, anxious, because our expectations aren't being met. And if we can more closely align that with the way the world truly is, we are less likely to do that to ourselves.
Yeah, you might address this now or maybe later on. We do have a question, Jeff. Question is, does it help for folks that feel not understood or respected by professionals in how to address the ongoing symptoms? So that's a question. If you want to answer it now, or if you're going to get to it, that's okay too.
I think bring that one back to me toward the end, because I think we're going to cover some aspects of that throughout the presentation, but it's a very good question.
And we appreciate the questions during, so keep them coming, and we'll take them as we go, or we'll push them off, but we'll make sure we get them answered. So thank you.
Some of them may steer the direction that we go with some of these discussions as well. So this harkens back to, again, remember I mentioned the first wave, which is behavioral therapy. We're talking about B.F. Skinner and colleagues who really looked at why do people and animals, they primarily studied animals, although B.F. Skinner studied his son a good bit as well. Why do people do what they do? And basically there is a stimulus and a response. So rat sees a light come on, presses a bar, gets food. Light's not on, presses a bar, doesn't get food. What you see is when the light comes on, the rat's more likely to press the bar. That stimulus and response is going back to the roots of behavioral therapy, which basically postulated that we act and feel the way we do because of cues within our environment. Those stimuli result in our responses, and because we live in a very rich and ever-changing environment, we have a very rich and ever-changing set of responses. So it can be very, very complicated, not just so simple. Cognitive behavioral therapy then brings in the role of our individual core beliefs. So what within our own brain are we filtering that through? We know that the exact same stimulus in the exact same environment doesn't always result in exactly the same response. And so that's really kind of underlying why those psychologists who originally developed these theories and principles were wanting to modify cognitive behavioral therapy, because human beings have this internal emotional state. We have these internal biases. We have these internal automatic thought processes that, again, allow for greater efficiency in dealing with a complicated world, but also put us at a disadvantage of potentially responding more to what's going on inside of our head than what's going on outside in the true environment.
Well, and I think what you're referring to is there's no one treatment, right? Because the filter of those internal beliefs is different for you and me, even though we might be experiencing the same thing.
Well, and the treatment may be the same, but the targets are going to be different. The goals are going to be different, and identifying what are those internal belief systems. We aren't born with these beliefs. They're really the sum total of our experiences and what we've learned from our environment, combined with observational data. We can observe others and learn from that as well. But a lot of this is just manufactured, either through our own imaginations or through stories we've read, books we've read, movies, TV shows we've seen. We learn from all of these sources throughout our lives. And you have to understand that the role of that echo chamber that exists when you're exposed to only a limited subset of ideas, information, and expectations really kind of locks you in to that belief system that is associated with that. So these core beliefs, again, operate at a level of subconscious. They are automatic. They allow us to, as I said, efficiently organize and predict information within the world. If you look wherever you're sitting right now, you probably got a desk in front of you or somewhere close by. There's probably a whole bunch of stuff sitting on that desk. Your brain automatically categorizes through what's called relational frames, all of the relations and associations of the object on that desk. What's above, what's below, what's beside, what's in front of, what's behind. Your brain does that automatically. And it's only when you consciously think about it that you realize that you're able to do that, and you do it automatically. There are also predictions that come up from the standpoint of the things that are on your desk right now. You can look at them and show yourself in your own kind of automatic way. What's the average, what's the overall weight of each of those objects? If I was to pick them up, what do they weigh? Your brain does that automatically. And again, there's an evolutionary benefit to a lot of automaticity when it comes to reacting to things within our world. But those are automatic. They result in an automatic thought from which our emotions and our conscious thoughts and our behaviors emerge. We are aware of what we're feeling at any given time, if we think about it, what we're thinking about, what we're doing, but we're not aware of that subconscious level. And that subconscious level, again, is based upon all this information that we've gained throughout our life through observing others. In either instance here, whether your beliefs are supportive or they're resulting in distress and interference, it's the internal core beliefs that are driving our thoughts and driving our actions, that are shaping our expectation to a given situation and how we feel about that situation. It's what we expect on the basis of that internal predictive algorithm that, again, your brain generates automatically, quickly, and at a subconscious level. The major triad of cognitive distortions was originally proposed by Aaron Beck in the late 1960s, and he hypothesized three major areas where our negative automatic thoughts tend to cluster. And Beck referred to these three as the negative triad. And you can see that they're overlapped there because they can all act together at the same time, given the situation. The first here, the distortion of self. A negative view of self is typically reflected in internal beliefs that give rise to automatic thoughts, assumptions, and reactions based on negative self-assessment. So I'm worthless, I'm ugly, I wish I was different. Those distorted views of self, as we'll talk about, can be very, very self-limiting in terms of what you feel that you're capable of doing. And can also then result in, of course, you not engaging in things that might otherwise be beneficial to you. It also results typically in depression. Depressive symptoms tend to be associated with this distorted view of self. The next in the list here would be a distorted view of the world, and this has to do primarily with others, sometimes simply categorized as others. And it's reflected in internal beliefs that give rise to automatic thoughts, assumptions, and reactions based around negative beliefs attributed to outside of the self. So the first one has to do with what we view internally. The second one has to do with what we view in the world. Other people don't want me. Nobody cares what I think. Others don't value my contributions. Or the more broad view that things should be orderly and predictable. When I make plans, everything should follow my expectations. This one is a little interesting when it comes to the fact that we live in an ever-changing world. Our whole life, we've had to adapt to change. However, we want things to stay the same. We want things to be orderly and predictable. And when they're not, if we have an overly emotional reaction to that, Now, it's okay to say, I don't like this. I wish this was different. It's very, very different to say, I can't stand this. This is the worst ever.
Mm-hmm.
And that reaction should be, should be aligned with the reality of what the world is.
Mm-hmm.
So again, it's okay to say, I wish that things were going my way more. It's another to say, I can't live like this because things aren't going my way. The more extreme views tend to be those that are more emotionally difficult for us to deal with. Lastly is the distorted view of the future. And this is one that really hits home when it comes to working with individuals after an injury. The belief that things are never going to get better. Actually, the only direction things can go are down. This distortion, again, is particularly applicable to individuals after a life-changing injury. They're in a situation, the individuals that we're working with after an injury, they didn't plan for this situation. They didn't expect this situation. They don't like this situation. If you have the belief system that things are never going to work out, things are never going to change, and nothing is going to improve or change, that my life is now ruined and things are always going to be this way. If you have that belief system and you act on that belief system, it is really difficult to get out of bed in the morning.
Mm-hmm.
The necessary energy needed to go through a rehabilitation program really means that individuals need a tremendous amount of positive support surrounding them to help see the potential that things can improve. Because after an injury, people tend to have recovery. It may not be back to baseline, but improvement is the direction things are going.
Yeah, this may be an unfair question, and I'm guessing there's a spectrum, but do you see often that there's one of these that is most front and center, or are quite often multiple areas, popping up that are impacting someone's ability to, move forward in recovery or things like that?
Well, I think kind of like the Venn diagram there represents, there are overlaps between these and you see them expressed in different ways. It kind of depends on the symptoms that you're seeing, and we'll talk about that in a little bit as well. When you're attempting to identify what is the underlying distortion that's resulting in this emotional or behavioral disruption, if it is a distorted view of self, it tends to be depression. If it's a distorted view of the world, anger, frustration. A distorted view of the future tends to be more anxiety than anything else. When we predict negative outcomes in our future, those aren't things that we want to happen, and we tend to feel anxious about the possibility of that occurring. That's when you wake up at 3 o'clock in the morning, worried about whether or not your HVAC unit is going to work for the next week, or is it going to crap out on you? You're at that point experiencing anxiety about something that hasn't happened, that may not happen. At some point in the future, probably will happen. It's probably better and more realistic to assume that at some point that will happen. But if it's not happening right now, should you be worried about it right now?
Yeah.
And as human beings, we have the ability to worry about stuff that hadn't happened, will never happen, that happened 6 years ago. Bringing in information outside of the here and now tends to be where a lot of anxiety tends to come from.
Yeah. Yeah, I think that's really, it gives some good clues as to what might be going on, right? When you look at the emotions that are tied to it. So,
yeah, these clusters are internally held beliefs, and they give rise to automatic thoughts, reactions, and behaviors. I keep saying that phrase over and over because it's all those things that come from these automatic thoughts, that come from these biases, these deeply embedded subconscious belief systems. We're not consciously aware that we're reacting to internal distortions of reality. They're truly biases that influence our thoughts and expectations. Within the assessment, again, of this emotional disruption, there are instruments. For example, Aaron Beck developed the Beck Depression Inventory, the BDI. It's a commonly used instrument, still around. There's a version of it that we utilize often within our environment, the BDI-FS. It's called the Beck Depression Inventory Fast Screen for medical patients. There are some medically based symptoms that overlap with depression, like fatigue, sleep disruption, appetite changes. And the BDI-FS attempts to minimize some of those purely physiological issues from the emotional issues that are more associated with depression. A major impact of attempting to emulate the ideals that you prescribe to others to approve of you generally results in a fairly compromised authentic self. If you're trying to be the person that you think everybody else wants you to be, as opposed to the person that you truly are. This is a core belief example that comes from that distortion of self. I have to be liked by everyone. And then some of the bullet points that you see there, if everyone doesn't like me, then I'm no good. So that's a huge leap from if somebody doesn't like me, then they don't like me. As opposed to I have to have everybody like me. In today's social media, you best not have this internal belief because no matter who you are, somebody out there doesn't like you. There are millions of people around the world that just because of who you are and where you live, think you are the most evil creature on the earth.
Yeah.
If you truly feel that everybody in the world has to like you, you've already lost the battle.
Yeah.
So again, if you try to be the you that you think others want you to be, you're going to come across as needy and disingenuous, agreeing with others to avoid conflict, attempting to give everybody what they want just so they will like you. That in a position of leadership is going to be devastating because just think of, as a leader, as a supervisor, as a manager, decisions you have made that are in the best interest of your organization, but not in the best interest of every single individual that is affected by that. Sometimes you have to make tough decisions, and those leadership decisions are not going to result in universal approval and agreement. If you have this cognitive distortion, if one person doesn't like it, you're devastated. You feel that you've done something wrong. So again, it really doesn't matter necessarily if other people don't like you. They're rarely going to come out and tell you that they don't like you. But we tend to react, even when people don't tell us that, we tend to react on what we think other people think about us. Now, we're one step removed from reality in that case, because we don't have access to other people's thoughts. We don't know what other people are actually thinking. We don't react to what other people are thinking because we can't know that. We react to what we think other people think. And so in that way, we're really doing that to ourselves. When it comes to making decisions, ideally, you should use the best evidence available to you at the time that decision is made and in the best interest of your mission or the underlying core values of yourself or your company. Now, that doesn't mean everybody's going to like it, but it also means it's not personal. We tend to personalize everything. They can say you're wrong, and they may have information you don't have. And once you get that information, you may change your mind. That's the scientific method. We believe something until we don't, and we have to have evidence to change that.
I had a friend who once told me this concept of your business and my business. And it has helped. It's really helped me think about if I have some of these thoughts, what Jeff, what you think about me is actually your business.
Exactly. Yeah.
Right. It's not my business what you think about me.
That's a me problem.
Right. That's a you
right?
problem.
Yeah.
Right. So I think that's really helped me when I start, falling into this trap of, well, is that actually my business or not? And if it's not, then that's maybe a bit healthier of a way to reframe it and look at it.
Yeah. It's not saying that you don't care what other people think. It's saying wait until you actually get the evidence of that, or they actually tell you. Don't act on the basis of what you think other people think. Try to stay as close to reality as you can. And for those of us that have been in this world for a while, with all of our learning and experiences, we know that the world is an ever-changing place. It is not very predictable. But if you spend your life thinking that the world should give you what you want, when you want it, and the way that you want it, you're going to have a lot of anger and frustration because the world really doesn't give a crap what you think, what you want, or when you want it. Other people tend to think about what they are thinking about at any given moment. I used to be early on in doing presentations, particularly before a big live audience, worried about what people are thinking of me while I'm talking. You're thinking them right now What am I going to have for lunch? What am I doing when I get home this afternoon? I wish the dog would quit digging up my shrubs. You know, what people are thinking in any given moment is rarely what we think they are thinking about. And when it comes to what other people think of us, our own mothers don't think of us as often as we think other people are. So that alignment of being, more accepting of the fact that the world is unpredictable. And it would be great if we got our way, but it also is not the end of the world when we don't, and not reacting to it as if that is the case. So we have all these underlying irrational thoughts that are represented typically in terms that are absolute. Absolutes are typically much more rare in the real world than they are in our mind. Instead of occasionally or sometimes, it becomes always or never. The absolute positivity that this must be this way or I can't stand it. Where we put ourselves at a disadvantage when we expect rigidity in a world where everything is in shades of gray. There's a continuum there. Since the world rarely fits into these exemplar terms, you're going to spend a lot of time disappointed, needlessly beating yourself up for not living up to a standard that no one can achieve. I've seen that in working with individuals as well who expect perfection. They don't expect necessarily perfection from everyone around them, but they do from themselves. Anytime you start to see some of these exemplar statements entering in to a sentence, must, should, can't, never, always, that is a clue that that is an irrational expectation. Should, never, that's rarely going to be the case, that it is that far out on the extreme. Some other irrational thoughts. Selective attention is one that we're all automatically pretty good at, and it's because our brains are designed to engage in selective attention. Our brains are designed to pick out what should be most salient and valent in terms of our expectations. We tend to see things that we expect to see. And that goes along with a lot of things that put us at risk. I used to ride a motorcycle. Cars that are pulling out onto the roadway look down the road, the individual driving looks down the road and expects to see a car or truck coming. They don't expect or anticipate to see a motorcycle because that's much more infrequent on the road. And as a result, if your brain is not primed to see that, you're less likely to see that. Can't tell you how many times individuals have pulled out in front of a motorcycle and their statement was, I didn't see them. Their brain saw them, did not process that as a valent signal, and therefore there is that risk. Our minds interpret information coming in and modify that data to fit our perception. If you've ever hung up some clothes on the outside of your closet and then in the dim light looked over and thought there was somebody standing in the corner, your brain has interpreted that signal, that information, and your perception has filled in the gaps to make it an even stronger emotional reaction that would have been the case. Our mind adds all the trappings of emotion and interpretation to a simply is situation. So we add a lot to that situation beyond what is. We decide in a deep internal way what the situation means as well. So again, our minds filter information and gives greater valence to those things that align with our expectations. We see those things more easily. What this means is if you are depressed, you are much more likely to see negative. If you are happy, you are much more likely to see things that are supportive of that. If you, in any given situation, expect or anticipate a certain thing, then it's going to typically be what you see the most. Here's one, magical thinking, and that is everything would be better if fill in the blank. If I was taller, if I was thinner, if I had more money, if I had more hair, I would be a different person. Well, it kind of goes back to the old, no matter where you go, there you are. Sometimes people try to make a major change in their life by just picking up and moving and going somewhere else, but they take themselves with them when they go. And so all of those things tend to be there.
I can't imagine you with more hair.
I could at one time. I was rocking a sweet mullet, man. Let me tell you.
Hey, that's coming back.
Oh, well, yeah. My son has one right now. So another big one is just, again, I've talked about this already, assuming that you know what other people are thinking and then basing your reactions on that assumption. You can see how these are very self-limiting thoughts. If you think somebody's going to reject you, why in the world would you ever approach them? If you see a business opportunity as a hopeless cause, why would you invest any time or effort into it? It's the sports saying of you miss 100% of the shots you don't take. So if you don't try, you're not going to succeed. Success depends on effort. You have to try to have a chance to succeed. I think, Thomas Edison really kind of brings this particular, went forward, brings this particular statement to light in that he said, in his search for the success for a good electric light bulb that would last more than, 5 minutes, I haven't failed. I've just found 10,000 ways that don't work.
Mm-hmm.
And so that perseverance, not just him personally, but his entire crew to continue working on it until they came up with a solution, that is a very important piece.
I think the willingness to iterate, right? We talk a lot about this with even with our treatment programs. Sometimes we're trying things that we don't always know will work.
Yeah.
But if we don't try, then we don't get more information. And sometimes, that new information allows us to tweak things and change things for the better. But there's the trust that like, hey, we got to give it a shot and take a small step forward.
Yep. And again, trying things. And if they don't work, it's not failure. It's not the end of the world. It's just, okay, that one doesn't work. Let's not do that again. Let's do that differently. So this is just kind of a whole list of irrational thoughts that individuals may very well have. False permanence. Your favorite band 10 years ago may not be your favorite band now. Things change. Overgeneralization. Applying the same outcome to every potential possible. Labeling, catastrophizing. That's the one I'm having to stamp down right now, that I'm about to take this long road trip and all the things that could go wrong along this trip. Can't stand it. Be aware of that one because that's one that we kind of put on ourselves. Yeah, we can stand it. It's not necessarily pleasant. It's not the best thing in the world. We'd like things to be different. That's a more realistic way of looking at it. Mind reading is a big one as well, because that really goes into us reacting not to what other people think about us, but what we think other people think about us. And because we know all of our own shortcomings and weaknesses, then that mind reading is being filtered through, expecting that that person also knows all of our shortcomings and weaknesses.
How much do you think awareness of these thoughts impacts everything, right? So being aware that I say I can't stand it, or being aware of your catastrophizing.
That's one of the things that I think therapy really kind of brings to the forefront, is making people aware of what they are doing and trying to realign that through all of the homework and expectations. So you really kind of led right into the next slide there. Pretty good, Steve. It begs the question here, if this is a subconscious and deep-seated below my ability to truly know what's causing these beliefs, how do I start to change these thoughts? So the process of CBT is really designed to develop insight into the fact that these automatic thoughts that are below our level of consciousness are impacting it, understanding that we often are doing this to ourselves much more than what we attribute it to, through a scientific process, dispute those irrational thoughts and replace them with things that are more aligned with the way things truly are. The process begins with assessment, which is attempting to identify where the disruption is occurring. What are the irrational interpretations that are resulting in these particular reactions, emotions, or behavior? And then acquiring skills through education, through kind of self-assessment, through our own experimentation. Are these aspects as well of things that can be taught, can be trained? Self-monitoring abilities, self-management skills, things like time management, relaxation, conflict de-escalation, and then training and consolidating those skills, which is the actual work of challenging those beliefs through experiences. The process involves teaching the patient the process. It really, you want to teach someone the skills of being able to self-challenge those belief systems and to carry out real life experiences that challenge those, guiding the patient's understanding of these automatic thoughts and teaching how to dispute them, teaching how to change those thoughts through our experiences. As I said early on, as human beings, we're hard-headed. We don't tend to change our beliefs unless our experiences necessitate that. And the process of CBT really is identifying what are those underlying beliefs, which are sometimes the type of emotional reaction you're seeing gives you that clue. If it's depression, tends to be self. If it's anger and frustration, tends to be the world. If it's anxiety, tends to be the future. And then facilitating action, assignments, practice, and repetition. This is where the learning mantras that we've talked about really come in, which is repetition, repetition, repetition. Just being told something is not adequate to change these internal beliefs. It requires us to act on those.
I think the other thing I would just add to that is step outside your comfort zone is another mantra that we use, right? So making sure that whatever homework is being prescribed or decided upon is actually stretching the person's abilities to do something, but also within the realm of what they're willing to try.
Yep.
Right. Because if it's too anxiety provoking or too
step.
big of a step, that's
Exactly.
not going to work.
So again, it's not enough just to be aware of these. You have to actively refute and replace them. And most of the change that occurs is in between sessions. It's outside of sessions. It's through some assignments that might be carried out, and it's through self-reflection. An example of this, social anxiety. People are looking at me. This is one that Ellis did early on with a young woman who was so anxious about what she thought other students on a college campus thought about her. Had her do a ridiculous experiment of walk across the campus and into the classroom, dragging a banana behind you, tied to your waist with a string. And to come back the next time and say, you didn't die, did you? Probably somebody might have asked, what's with the banana? But then they moved on. So, the entire campus did not line up to point and laugh as you walked past. The fact that most people are more concerned with their own lives than they are yours. And so just be aware of that. So that is a physical exercise that was given to challenge that. It's also bringing in different tools that can help solidify the successes that one experiences in doing these homework assignments. Again, you want to reflect on that success because that reflection is actually part of the repetition that is positively changing that. These are different ways you can have a patient review and repeat those experiences. So again, what happened when you challenged that particular belief system and what was the result? If it is different than what you anticipated, be aware of that difference, reflect back on it, repeat that to yourself, and be aware that your belief system is now being modified because of that. It's building a stronger neuronal pathway. It's neuroplasticity at its base so that these new routines become the default network of how to interpret and how to see things. Journaling is something that can help us review the previous weeks and patterns. It can help us in designing future exercises or challenges. Again, it's meeting somebody where they are and not pushing them beyond their comfort zone. They have to be willing to attempt some of these experiments that are involved. If it's social anxiety, sometimes it might just be involved, go up and ask a stranger a question and realize that, there's not that level of rejection that you anticipate.
Mm-hmm.
Graded exposure, overcoming avoidance through a stepped process of exposure. Again, small steps working toward that goal, achievable goals. You want success early on because that success gives you motivation to continue pushing forward. And then experiments, which is actual kind of in the real world exercises. If I do A, how is that different than when I do B? What is the reaction to that? Is it what I expected? If it's not what I expected, do I need to modify on that basis? Like every other kind of learning, most important aspects are repetition. It has to be meaningful. You have to have a reason to do a difficult thing. You have to tie it to a specific task or situation. And then you really have to push yourself beyond your comfort zone to repeat and repeat and repeat. So why is CBT something that we're talking about when it comes to individuals after a brain injury? First and foremost, depression is very common following traumatic brain injury or acquired brain injury. Depression doesn't always present in the classic DSM diagnosis fashion as well. Difficulties with self-monitoring and awareness or deficits in memory can make it difficult for someone to have an ongoing sense of how they're doing and how their mood has been. So you need to look at other indications of depression. Again, caution with this because some of these overlap with the physiological aspects of injury, loss of sleep, loss of appetite. What is most helpful likely is descriptions from family and caregivers of loss of pleasure from previously enjoyed activities and events. People who know this person best being able to say, no, this is something that is different. You have to be aware of the complex link between depression and aggression as well. There are increases frequently in the intensity or frequency of irritable, angry, or even assaultive behavior that can be reflective of depression more so, particularly after brain injury. That's something that when it comes to depression is more common in adolescents than in adults, that agitated type of depression. But because of frontal lobe deficits following brain injury, you also tend to see that variability as well. And so is it situational? Yes. Biochemical? Yes. Neurological? Absolutely, after a brain injury. And social changes as well, and social roles. All of these are things that you need to be aware of. Again, between 27 to 61% of individuals with brain injury develop depression or worsening of depression for those that had experienced and previously been diagnosed. And again, these are diagnosable levels of depression, not people that show symptoms of depression, but people who show all of the symptoms necessary to diagnose this. These rates don't take into account those that have symptoms of depression, but don't meet the full diagnostic criteria. Emotional disruption following brain injury, again, is associated with poorer outcomes. And again, that's why it's important that it be treated as effectively and quickly as possible, because it affects quality of life outcomes. It can also amplify some of the other neurobehavioral challenges. Individuals who don't have a history of a brain injury often have cognitive changes when they are experiencing depression. And anxiety and depression get in the way of our cognitive processes. And so to maximize where someone potentially could be from the standpoint of their cognitive recovery, we want to eliminate this interfering factor of depression and anxiety to the degree that we can. Anxiety disorders are much more common, particularly generalized anxiety disorder following a brain injury. And there's a huge overlap here with symptoms of other issues when it comes to brain injury. So there's an overlap between many post-concussive symptoms and some of the core symptoms associated with generalized anxiety disorder. I've seen a number of cases, particularly even complicated post-concussive, that post-concussive syndrome, where anxiety is a primary issue that was not prior to that injury. So headache, dizziness, blurred vision, irritability, sensitivity to noise and light, these are all things that are associated with concussion. They are also, typically some of these are associated with diagnosis of anxiety disorder, feeling restless, feeling on edge, being easily fatigued, difficulty concentrating, sleep disruption. If these symptoms weren't existent for this individual prior to a TBI, clearly they're going to be secondary to the injury. If they did exist previously, they could be worsened substantially by the TBI. And when it comes to emotional disruption following brain injury, other things as well, obsessive compulsive disorder is much more common. There's an interesting relationship between the severity of injury and PTSD. There's some evidence emerging that individuals who experience a loss of consciousness of greater than 15 minutes typically have reduced PTSD rates compared with those with more severe injuries. Part of that likely has to do with the interruption of the neural substrate associated with memory and recall that occurs when you have a severe injury. If you do not have any first-person association with the injury itself, you're typically not going to have an emotional reaction to that. That lack of knowledge about your own injury. What most people with a severe traumatic brain injury know about their injury and can self-report is what other people have told them as they have now emerged from post-traumatic amnesia and are holding on to that information. So we've covered the what and why. Let's go into the who when it comes to this. One of the most empirically well-supported interventions and treatments for depression in the general population is CBT and those third wave cognitive behavioral therapies that I mentioned earlier that are based upon the same principles and underlying constructs of CBT. There's empirical support for use in adults, for children, and adolescents. For chronic pain, third wave process of acceptance and commitment therapy, something called ACT, is typically something that is focused for that. The third wave cognitive behavioral therapy of CBT, developed by Marshall Lanahan, which is really focused more on personality disorders, things like extreme emotional reactions and how to better learn to deal with one's own emotional status. So all of these things, anxiety disorders, depression, PTSD, chronic pain, these are all things that respond well to CBT. And because it is useful for treatment in the general population with these issues, it's also demonstrated utility and effectiveness when it comes to individuals who have sustained a brain injury. And here are just some rates showing treated CBT treated versus untreated cases for depression, for anxiety. Again, it's a goal-oriented process looking at a specific target. It blends well with our conceptual understanding of neuroplasticity. It involves teaching, training, repetition, and the ability of the brain to change in response to our experiences, enhanced by engagement and enhanced by repetition. It is not the best treatment for everything. CBT, again, is very targeted and goal-oriented, so it is not going to be the everything treatment. It is identifying specific ways in which an individual's internal belief system is interfering with their process of recovery or interfering with their emotional health. You have to be aware that with a more severe injury, you may have a lack of awareness. If you don't have accurate self-awareness, it's going to be difficult to self-evaluate and to compare your expectations and outcomes. So severe memory deficits or awareness issues may very well necessitate some significant adaptations when it comes to CBT. The other is just different adaptations for a population of individuals after brain injury. An individual may need more cueing, may need increased repetition, something that someone without a brain injury might be able to pick up with 4 sessions, may need 8 to 12, may need longer time just for the amount of repetition that is needed. It is increasing the automaticity, again, the subconscious aspects of that. So you don't necessarily have to have the ability to accurately reflect back to still benefit from changing some of these belief systems through your own experiences. If there's decreased attention involved, you might do shorter sessions, limiting the goals, making the steps smaller along the process, and then using written notes and reminders, all things that are typical for individuals after a brain injury. Support for that. There are several studies pre-COVID that found that CBT is effective and is not platform or format dependent. So similar results are observed for internet-assisted or telephonic delivery of services. So remote services can actually be very helpful with that. Receiving services at home is also a more comfortable environment for some folks as well. And so as telerehab has advanced, particularly through the pandemic, having that option is a huge benefit for folks to be able to receive treatment in their own environment. If you want to learn a little bit more about QLI's rehab program, they rebranded a couple of years back and are now known as Continue Telerehab. Just wanted to include their website information in case you're interested in seeing how QLI's tridimensional model translates to a telerehab platform. Questions that are remaining are general dose. I think it's going to vary by patient, but typically around 8 to 12 hour-long sessions is what you would target. It depends, again, on some of the cognitive adaptations for which adaptation might be necessary. But looking at it's going to vary by person and by issue. Studies really haven't advanced to the point of comparing individual face-to-face therapy with group-based therapy. Both have shown benefit, but the bottom line is that people are complex. And so even when you isolate a group of individuals to study with a particular clinical characteristic, there are a lot of different factors, and how an individual is going to be able to incorporate these things is going to vary. It's going to really need to be very individualized in most cases, because you're talking about one person's internal belief system and how you can address that and modify that over time.
So just to clarify, we did have a specific question on, groups versus individual. I'm sure there's situations where a group will work, but you're saying kind of given the individual nature of each one of us and injuries and things like that, that's probably the direction you would lean, if I interpreted that, or how would you clarify that?
Well, my own experience, again, working with individuals with severe brain injuries, is that there's a lot of modification and adaptation that's typically needed for that. Therefore, it's rare within a group of individuals who've sustained brain injury that everybody is dealing with the same issues. Brain injury as a diagnosis is so far away from a homogeneous classification that it's almost useless. It's a diagnosis on the basis of injury, not on the basis of presentation.
But maybe perhaps for chronic pain, spinal cord injury, limb loss, maybe where there's not those cognitive, like inherent cognitive deficits, but rather other interferences.
Any situation where there are going to be some common irrational thought processes particularly associated with other people and how other people view me. That is a very common one. And so addressing that in a group environment can sometimes be more beneficial, because people see that it's not just me, it's everybody that deals with this. And that's kind of one of the benefits of group processes in general, is understanding how this applies kind of across to the human condition, not just to me.
Okay. Well, here again on the screen, as a reminder, Dr. Jeff Snell, thank you so much for joining us today. Here's Jeff's contact information. We do have some questions that we'll try to get through based on the time that we have left. I am going to launch the poll. As a reminder, please answer this poll question. This is part of how you get your CEUs. This is the only poll question. So I'm going to go ahead and launch that, and then Jeff will go ahead and take a few questions as well. One, maybe kind of similar to the group versus individual. There's a specific question around, like, how does this actually happen in practice? And I know you've touched on some modifications and in-person versus telehealth. Maybe you can expand a little bit more, but when I hear this question, I think of, a lot of our residents meet formally with you or someone from your team, but there's a lot of CBT going on more broadly, right? With the physical therapist or with the RT in the house, and it's really functional too. So that's partly what I go to, but how do you answer that question very quickly around how does this actually look in practice?
Well, in practice, first and foremost, like I said, if you're sitting down with someone for the first time, it's identifying kind of what are the major emotional experiences that individual is self-reporting, the type of experiences, the type of emotional reactions that they're talking about will typically give you a little bit of clue of which of those triads you're probably going to focus on. And then it is challenging what are those belief systems that are underlying that particular emotional or behavioral reaction. So if it is more involving negative self-evaluation, it is then challenging that through experimentation with that particular individual, having them go out and do things. Again, the activation, which is so critical to this, a person's own experiences. If a person is anxious about speaking in front of a group about something, if that anxiety is present, again, that anxiety probably reflects, I worry about what other people are going to evaluate me, what other people are going to think about me when I'm doing this, and challenging that. First off, providing information, which is we know that other people don't think about us nearly as much as we think they think about us. But then challenging that as well to actually do things that might otherwise be embarrassing.
Mhm.
And to realize that if that occurs, if the worst case, you don't want to put somebody in the worst case scenario. But if it goes in that direction, is that the end of the world? Is that survivable?
Mhm.
I have a bad habit of saying even when I'm presenting, and I'm aware of that. And occasionally I become consciously aware of that. And in that moment, then that starts to obstruct my
Mhm.
ability to think in other directions. Does it happen? Yes. Is it the end of the world? No. Is it irritating for you to hear me do that? Probably.
Well, I will say the question and answer is blowing up about the quality of the presentation. So the group loves it. So
Great.
and no one said anything about because they're not really thinking about you that much.
Well,
remember, Jeff?
but now I've brought it to your attention. You're going to hear it every time I do it.
Another one, we're coming up on time, but this is I think related to what we've been talking about. How do you know when someone is ready to be released? Are there any metrics around decision making in terms of effectiveness, that sort of thing?
Part of it is successful completion of, those assignments, those things that we ask people to do in between. It's reflected often if they are journaling in their own self-assessment, when their internal voice starts to kick in for what information the therapist is providing, they become their own therapist in that case. So they basically learn the skills to challenge these irrational beliefs and to change them through action, and so that they can carry that forward. I don't want somebody to have to come back to me, okay, now because I've got a different kind of irrational belief. No, I can use the same template to address that. And so I kind of know now what you would tell me as a therapist. I kind of know what you're going to say, and I want to move forward with it.
Yeah, there's a
And it's
scaffold.
based on experience, not my expectation of what you're thinking and going to tell me.
And so there's a scaffolding and a fading of support, and just like we see with a lot of our other therapy treatments. And there's another question around time frame. You had mentioned 8 to 12 weeks
Typical
is pretty typical in terms of severity of injury. I would guess you would say that can impact the time frame.
The more disruption of cognition exists, the more accommodations, the more support, the more time that may take.
Yeah, and I think the other thing that I often see is you might be addressing a particular issue today, and you start to work through that, but inevitably there's another thing that's kind of layered on top of that, or there's another goal that pops up that might create some other challenges. And so I always think of the time frame is really dependent on the goal and dependent on the situation, and so there's a typical time frame, but with the individuals we work with, there's this level of complexity that's tied to it. And for someone who's really going back to their full life, right? So work, being a spouse, or being a caregiver of someone, or going back to school, there's a lot of different challenges that continue to pop up. And so I think there's this idea that CBT is also finite, and I think there's an opportunity for it to be a little bit more maintenance based and long term, depending on the situation, so that people can sustain progress and feel like they can deal with the seasons of life. I don't know how you feel about
we
that.
all kind of benefit from a little bit of extra support occasionally. So when we have a slump, when we have a downtime, it's beneficial, I think, sometimes for somebody to bump us back up a little bit and remind us of what we know and what we're capable of.
Yep. Well, we are 3 minutes over. For those of you who didn't answer these, get your questions answered, we'll go through these. And if I cannot answer them, I'll have Jeff do those, and we'll get you squared away there. Looks like everyone has answered the poll. As a reminder, the poll is to get your CEUs. The other way to get your CEUs is we will be sending you a follow-up email with a webinar evaluation that triggers the CEU certificate and the slides. So I believe that covers us on the housekeeping. Again, thanks everyone for joining. We will be back next month with a presentation specific to tele-rehab. If you've heard that presentation before, we do always try to tweak them and involve new information based on our experience. So it will not be the same presentation you've seen. And again, we appreciate everyone's questions and participation. And Jeff, thank you again for joining us. And
thanks for hosting, Steve.
And we're always here for you on your 18-hour drive to be your support for success. But I think you're in good hands with